Hey everyone, welcome to USMLE with me, where we break down high yield questions one at a time to get you ready for exam day. Today we're going to tackle a question that is pretty high yield for step one as well as step two CK. And I wouldn't be surprised if you found this on an internal medicine shelf near you. All right, so very classic question, classic presentation. So let's get into it. Here's your question. And at this point, you can feel free to pause and try the question for yourself. One thing to keep in mind is you have 90 seconds per question on any given USMLE exam or clinical shelf exam. So you want to get in the habit of doing everything you need to do in that 90-second time. That's reading the question stem, read the question, interpret the lab values. I always like to have an idea of what the answer may be before I head into the answer choices. So you have to kind of develop that and then choose an answer. You have 90 seconds. All right, so feel free to pause. Otherwise, we're going to start here together. All right, so let's do this. What is the most likely underlying cause of this patient's condition? We have a 32-year-old woman presenting with a 3-day history of spontaneous bruising and petechiae on her arms and legs, increased gum bleeding while brushing her teeth, no significant medical history, no medications. Physical exam, we have scattered petechiae and ecchymoses, but no hepatosplenomegaly or lymphadenopathy. Here are the lab values. So I work with students one-on-one for the step two CK, USMLE step one. One of the things I've realized that some students have a habit of is they like to open up their lab values and they like to go line by line. Somebody taught them or somehow they picked up this habit where they're going to go for each lab value and say normal, abnormal. Then they're going to use the references sheet and go back and forth. That's a mistake, right? That's a mistake. We have 90 seconds. We don't have time to evaluate with that way using our references list. So over time, you want to practice. It comes with practice. And you really want to have these lab values memorized. I don't lean so heavily on memorization. I don't lean super heavily on mnemonics, but sometimes they're really useful. And sometimes memorization really is just, it's necessary in some cases. This is one of those cases. So our hemoglobin is 12.8. White WBCs are 6,200. Platelet count is 18,000. PT is 12.3 seconds. Activated PTT is 31 seconds. Everything here seems within normal limits with the exception of that platelet count. 18,000 is super low. All right, that's super low. We have a peripheral blood smear showing isolated thrombocytopenia without schistocytes. So which of the following is the most likely underlying cause of this patient's condition? If you haven't already, pick an answer. Feel free to put your answer in the chat or in a comment. Maybe put your diagnosis. If you have a particular diagnosis that you're considering, feel free to share that. So let's get into it. First of all, there's something that I like to do. It's like an umbrella diagnosis or like a I call it a trigger diagnosis. What that means is that when I see certain things, I have a short list or an umbrella that I'm considering. So here we're definitely dealing with thrombocytopenia. The platelet count is super low, and I have four key differentials for thrombocytopenia, which I immediately consider in such a context. Here are the four differentials: immune, thrombocytopenic, purpura, ITP; thrombotic, thrombocytopenic, purpura, TTP; disseminated intravascular coagulation, DIC; and hemolytic uremic syndrome, HUS. The cool part is all four of these, what they share in common is thrombocytopenia. All four of them have a 3-letter abbreviation. And all four of them they have distinguishing features, which we'll talk about. And in that context, that's why you'll see these often as shared answer choices for any given situation of thrombocytopenia. But this is my key differential. These are the four differentials for thrombocytopenia that I always have in mind. It's not exhaustive, but they're very high yield to know. All right, so why don't we get into this question? We'll start off with TTP because that's one of our key differentials. It's also one of the answer choices here. The thing about TTP is it has a constellation of symptoms that you don't actually see them here. So this is actually where I do have a useful mnemonic. You may have heard it before, you may not have. It's called FAT RN. Okay, now RN, don't get me in trouble. I didn't make this mnemonic. RN does not stand for registered nurse. All right, it stands for something different. So don't get mad at me. We love our nurses. Here's what it stands for: fever, anemia, thrombocytopenia, renal, neuro. Okay, renal in the sense that in this context they would give you an elevated creatinine. Neuro is one that students tend to miss. Neuro, the way that they would hint at that in the context of TTP would be confusion, disorientation, something of that nature. Okay, so here we have thrombocytopenia, but we don't have that constellation of symptoms, that pentad that I'm really interested in. So TTP would be a less likely diagnosis. Okay, why don't we evaluate DIC, disseminated intravascular coagulation? Why is that not a consideration? I actually want to pause here. me see if you can tell me. There are actually a number of reasons why I wouldn't consider that very strongly here. It's part of the differential, but there's a reason why it's not the wrong, rather, there's a reason why it's not the right answer. Good. I hope you're pointing to the PT and PTT. Okay, so disseminated intravascular coagulation. A lot of times students memorize this. I don't suggest memorizing in this situation. I feel like understanding is very powerful here. What is DIC? This is a pathologic activation of the coagulation cascade. What is the function of a coagulation cascade? Ultimately, it's to produce a stable fibrin clot. So, a pathologic activation of the coagulation cascade, which DIC is, it should form a clot. So then the question is, why do we have bleeding? Why do we have elevated PT and elevated PTT in DIC if we have a pathologic activation of the coagulation cascade? Well, what ends up happening is this activation of the coagulation cascade eventually leads to consumption of those clotting factors. That's why this is known as a consumptive coagulopathy, a consumptive coagulopathy. And that's why in DIC, eventually, you actually have a depletion of those clotting factors. You actually have elevated PT, elevated PTT, and yes, that's why you see profuse bleeding, bleeding from any orifice, bleeding from venipuncture sites, nosebleeds, etc. So that's something that distinguishes DIC from our picture here. What else would distinguish it? Well, here we have a peripheral blood smear. We don't have schistocytes. Here's the thing about DIC. DIC is one of the microangiopathic hemolytic anemias. Okay, so you would have evidence of microvascular thrombosis. In other words, on peripheral blood smear, it's very likely that you would see schistocytes. This highlights a very important test-taking strategy. Now, a lot of times, I'm working with students, and what I realize is a lot of times students have the content. They've seen all the review videos, they've read all the books, they've done all the Anki cards. What they're missing is that last piece, which is test-taking strategy. I'm going to introduce this principle to you, and it's going to come up a ton of times in the future. It's this idea of pertinent positives and pertinent negatives. Now, here we were told that there are no schistocytes. That's a pertinent negative. Here we were told that there's no hepatosplenomegaly or lymphadenopathy. In the context of a bleeding problem, that is a pertinent negative. Here we were told that the hemoglobin and white blood cell count are normal. Those are pertinent normals. So it's not necessary that every single piece of information in the question is absolutely important. You get good at parsing what's relevant versus what's not over time. But you don't want to just focus on what's abnormal. I find that students are able to point out, oh, that platelet count, oh, this patient's bleeding. You can point that out. But why is it important to note that there are no schistocytes? Why is it important to note that the PT and PTT are normal? I hope you're seeing that these pertinent normals actually help you. You have your differential, but then eventually you got to choose one thing. And the pertinent normals can help you just as much as the pertinent abnormals. Okay, so in DIC, we would expect, more than likely, we would expect schistocytes. We would also expect fibrin degradation products or fibrin split products or elevated D dimer, all ways of saying the same thing. We would expect those findings which are not given here. Okay, moving on to bone marrow failure. Why is this not bone marrow failure? So again, it turns out to the pertinent normals. Your bone marrow is responsible for cellular lineages. It produces so many cell lines. And here we have a normal hemoglobin, and prominently we have a normal white blood cell count. Your RBCs and your WBCs, these cellular lineages that are built in the bone marrow or produced in the bone marrow, they would be decreased. Okay, so you not just have an isolated thrombocytopenia, you would have a decrease in all cellular lineages. Additionally, I mentioned the no hepatosplenomegaly. That is a relevant, or that is a pertinent normal, or that is a pertinent negative. You don't have hepatosplenomegaly. Why is that important? In bone marrow failure, you have this concept of extramedullary hematopoiesis. Okay, extramedullary hematopoiesis. What's going on there? What's going on there is that when you have bone marrow failure, when you have profound severe anemia, there are organs in the body that they will in certain cases try to take over when the bone marrow is not able to produce cellular lineages. The liver is certainly one of those organs. The spleen is one of those organs. Why do you think we see hepatosplenomegaly in myelofibrosis? Why do you think we see hepatosplenomegaly in certain lymphomas? Okay, why do you think we have the characteristic chipmunk faces in the thalassemias? Remember that widening of the skull and those widening of the skull spaces in thalassemias where you have profound anemias. These are manifestations of extramedullary hematopoiesis, which this patient does not display. Okay, so bone marrow failure is not the best answer. So here we're between A and E. Let's talk about vitamin K deficiency. What are the factors? Say them out loud. Don't worry if you look crazy. All right, studying can be crazy sometimes. If you're on the bus, if you're in public, say them nice and loud. What are the clotting factors that are typically activated by vitamin K? All right, I hope you said 2, 7, 9, and 10. I hope you said 2, 7, 9, 10. That's vitamin K. So in that situation, if you had a deficiency of those clotting factors, you would see a prolonged PT. You would see a prolonged PTT. Okay, so this patient doesn't have that. So that leads us to our answer, which is autoimmune platelet destruction. Of course, this is lending towards immune thrombotic purpura. Okay, immune thrombotic purpura or immune thrombocytopenic purpura. All right, that's your diagnosis here, and that is autoimmune platelet dysfunction. Okay, so before I move on here, one thing I wanted to point out is I was working with a student on a very similar question to this, and they said, well, I think that this is maybe von Willebrand disease, or I think that this is maybe a bleeding disorder like a hemophilia. And that's a fair idea. This patient is having bleeding, they're having some bruising, they have petechiae. But why is this not a primary bleeding issue? Why is this not von Willebrand disease or hemophilia? Okay. Remember, with the hemophilias, we have hemophilia A and B, which are X-linked recessive, and then we have hemophilia C, which is autosomal recessive. But why, or why is this not one of those things, or why is this not Bernard Solier? I hope you're pointing to the PT and PTT. Okay. With the hemophilias, certainly your PT and your PTT would be elevated. With von Willebrand disease, your bleeding time would be elevated. And sometimes, not all the time, but sometimes in von Willebrand disease, you actually also see your PTT as elevated. Of course, with Bernard Solier, you would see an elevated bleeding time. But most prominently, those bleeding disorders do not have a quantitative platelet disorder. They're not going to have thrombocytopenia. That's why I started this discussion talking about that differential when you see thrombocytopenia. This is where it helps to have that organization rather than just tons of information in your head. Because if you're able to identify that the platelet count is the most important thing to stem your umbrella and stem your differential from, you're not going to get distracted with the bleeding. Otherwise, you're going to think of all these bleeding disorders, but you're going to miss that key point. Those bleeding disorders, unless there's a concomitant pathology going on, which is impacting your platelets, which would be pretty rare to see something like that happen on an exam. Those bleeding disorders like von Willebrand, hemophilias, etc. Those do not have an abnormal platelet count. Okay, platelet count will be normal in those situations. Okay, so feel free to take a look at the answer explanations. You can pause here. You can take a look. We pretty much went over this. Okay, so we went over this. You can pause. You can take a look. And here are our final takeaways. All right. We mentioned most of these things. Aplastic anemia, you would not see just the platelets. You would also see low WBCs. You would also see low RBCs. One of the concepts that I think would be great for another video later would be heparin-induced thrombocytopenia. In fact, you can go ahead and put what are those antibodies in heparin-induced thrombocytopenia which attack those platelets? What are those antibodies called? And I'm going to make a question on this because it's very important. Sometimes students miss this part. There are destructive autoantibodies to platelet components in heparin-induced thrombocytopenia. However, you also have activating autoantibodies, which activate the platelets. So HIT, whether it's HIT 1 or HIT 2, heparin-induced thrombocytopenia is one of the rare times where you will have low platelets, but hypercoagulable state. And that's why it says here there's a paradoxical thrombosis. Even though you're destroying platelets, some of those antibodies are actually also enabling or they're incentivizing or they're amplifying platelets. And so therefore, you have a paradoxical thrombosis. Really, really great, really great concept for a future video. And then you have liver disease. Now, liver disease itself can cause thrombocytopenia. It can also cause a vitamin K deficiency. All right. So your high-yield takeaway here is that isolated thrombocytopenia with otherwise normal coagulation studies and no hemolysis on peripheral smear strongly suggests immune thrombocytopenic purpura. All right. Immune thrombocytopenic purpura. All right, so that wraps up today's session. Thanks for tuning in to USMLE with me. If this breakdown helped, follow, subscribe, comment, whatever platform you're on. Just keep in touch. And as always, tackle things one question at a time, one step at a time. Imagine if you learn just one thing every single day, how much progress you would make in the long term. Sometimes we overestimate what we can accomplish in a day, but we underestimate what we can accomplish in 3 months or a year. So focus on learning and taking one step every single day. And if you need help, I'm always here to help. Okay, so stay sharp, keep grinding, and and happy studying.